Hello everyone, welcome back to osteology classes. Today's topic is on femur. Femur is the longest bone. You can see in my hand, this is the longest and strongest bone. It is the thigh bone located in the thigh. The length of the femur is approximately 40 to 45 centimeters in adults, and it has got the upper end, lower end and the shaft. Like any other long bones, it has got upper end, lower end and shaft. And upper end, the prominent feature is the head here, and head articulates with the acetabulum of hip bone to form hip joint. And other features of upper end, we can see two projections. Laterally one projection which is called as greater trochanter. This large projection is the greater trochanter, and the small one which is posterior-medially, this is the lesser trochanter. And lower end, anteriorly the femur articulates with the patella, where we can see like a saddle like depression. This is articulates with the patella. And inferiorly we can see the two condyles of femur, medial condyle and lateral condyle, which articulates with the tibia to form a part of knee joint. So parts, upper end has got head, greater trochanter, lesser trochanter, and we know this is the diaphysis or the shaft of the femur. And lower end has got medial epicondyle and lateral epicondyle. Let us understand the anatomical position and side determination of femur, whether it is right or left side. To determine the side, the upper end, that is the head, should be directed medially, and greater trochanter is on lateral side, lesser trochanter is posterior-medially. The anterior smooth part of the shaft, is smoother, whereas the posterior part is rough. This rough part, posterior part, is called as linea aspera. So anteriorly it is smooth, the rough posterior part. So if we keep in anatomical position, just put your finger underneath the neck. So if it is inclined medially, that side it belongs to. So this is the head, greater trochanter, lesser trochanter. Linea aspera is directed posteriorly, and lower end anteriorly both the condyles are continuous with each other. We can see they are continuous with each other. And posteriorly we can see a deep notch which is called as intercondylar notch. So upper end, we know this prominent feature is the head, which articulates with the acetabulum to form hip joint. In the center of the upper end, we can appreciate a pit which is called as fovea capitis or fovea. Fovea capitis provides attachment to ligamentum teres femoris. Ligamentum teres femoris attaches to this pit called as fovea, which connects to the acetabulum. Neck, the neck of the femur, the neck makes an angle with the femur which is called as neck shaft angle, and the neck has got the upper border, lower border, and anterior surface and posterior surface, and anteriorly the neck joins with the shaft at a line which is called as intertrochanteric line. This is called as intertrochanteric line, which continues with the greater trochanter above, and inferiorly if we trace down, it continues till the lesser trochanter. This line is called as intertrochanteric line. Intertrochanteric line provides attachment to capsule of the hip joint, and it also gives attachment to iliofemoral ligament or ligament of Begilo, which is the strongest ligament of hip joint. And upper part of the intertrochanteric line, it is continuous with the lateral lip of the linea aspera posteriorly if we trace. So upper part provides attachment to the vastus lateralis. Lower part of intertrochanteric line, if we trace, it is continuous with the medial lip of the linea aspera. So it provides attachment to vastus medialis. So these are the structures attached to intertrochanteric line. So I repeat, capsule of the hip joint, iliofemoral ligament or ligament of Begilo, vastus lateralis, vastus medialis. These are the structures attached to the intertrochanteric line. Posteriorly, the upper end connected to the shaft by a crust which is called intertrochanteric crust. This thick bony ridge what we are seeing is the intertrochanteric crust. This is the lesser trochanter which is prominently seen on posterior side. Here is the greater trochanter, and in the intertrochanteric crust over it we can see a elevation. This is called as quadrate tubercle. It is called quadrate tubercle. Quadratus femoris attaches to quadrate tubercle. The greater trochanter, which is the larger prominence of femur, greater trochanter provides attachment to piriformis at its tip. So, we can see this curved part of greater trochanter. This curved part provides attachment to tip of it, piriformis is attached. Laterally, we can see the greater trochanter. It is divided by an oblique ridge. This is an oblique ridge dividing into upper and lower parts. So, the upper part, it provides attachment to gluteus medius muscle, and the lower part gluteus minimus muscle. Gluteus medius and minimus attached to the lateral side of greater trochanter. Both are the abductors of hip joint. On the inner aspect, this is the inner side of the greater, medial side of the greater trochanter. Medial side of the greater trochanter presents a deep fossa. This is called as trochanteric fossa. It is called as trochanteric fossa. Within the trochanteric fossa, the two gemelli, that is the superior gemellus, inferior gemellus, and one more muscle called as obturator internus, all three muscles insert into this trochanteric fossa. So, obturator internus, superior gemellus, inferior gemellus attaches to the trochanteric fossa. Above the trochanteric fossa, below the tip, we know the tip provides attachment to piriformis. So, below the tip, obturator externus also attaches. So, the lesser trochanter, this mountain like projection, the small projection is the lesser trochanter, prominently seen on the posterior aspect. So, the lesser trochanter provides attachment to psoas major and iliacus. So, the base of the lesser trochanter to the iliacus, the tip of the lesser trochanter to psoas major. Psoas major and iliacus together form a tendon called as iliopsoas tendon. So, iliopsoas tendon attaches to the lesser trochanter. So, the anterior surface of the shaft, we can see it is smooth all over, and most of the anterior surface, lower part of the anterior surface of the shaft provides attachment to vastus intermedius muscle. Vastus intermedius muscle is the deeper muscle in the anterior compartment of the thigh, which gains its origin from the anterior surface of the shaft of femur. Let us see the posterior surface. The posterior surface of the shaft of the femur is called as linea aspera. You can see this rough part is called linea aspera. It has got the medial lip. This is the medial lip of the linea aspera, which continues to form medial supracondylar line, and lateral lip of the linea aspera continues to form lateral supracondylar line, which is above the lateral condyle of femur inferiorly. And in the linea aspera, on the lateral side, we can see a rough impression. This rough impression is called as gluteal tuberosity. On the near the lateral lip of the linea aspera, upper part, we can appreciate this rough part, which is called as gluteal tuberosity. Gluteal tuberosity provides insertion to gluteus maximus muscle. So, 1/4 of the gluteus maximus muscle inserts into gluteal tuberosity, and rest of the 3/4 of gluteus maximus muscle inserts into iliotibial tract. So, that is about the gluteal tuberosity. Now, let us understand the muscle attachments to linea aspera. So, here this rough part is the linea aspera, we all knew that, and the upper rough part, this part is the gluteal tuberosity, and the linea aspera, it has got the medial lip of the linea aspera, which continues to form medial supracondylar line, and the lateral lip of the linea aspera continues to form lateral supracondylar line. Medial lip, if we trace, it is continuous with the trochanteric line. It is continuous with the intertrochanteric line, whereas the lateral lip, it goes to the base of the greater trochanter, and it continues on the other side with the intertrochanteric line. Now let us understand the 9 structures attached to this linea aspera. So this is the medial lip of the linea aspera, and here is the lateral lip of the linea aspera. And the medial lip provides attachment to medial intermuscular septum. So along the medial lip there is medial intermuscular septum, along the lateral lip there is the lateral intermuscular septum, and in between there is the posterior intermuscular septum. So that's how we can divide. So this is the medial intermuscular septum, this is lateral intermuscular septum, and here is our posterior intermuscular septum. And medial to it, if you see, the medial to the intermuscular septum, the rest of it continues to form anterior side. Lateral to the lateral intermuscular septum, it continues with the anterior compartment. So in the thigh there are 3 compartments: anterior compartment, medial compartment, and posterior compartment. Anterior compartment is the quadriceps compartment, mainly quadriceps femoris is present. Posterior compartment is hamstring, whereas the medial compartment is the adductor compartment. So lateral to the intermuscular septum, lateral to this intermuscular septum, vastus lateralis, this part, vastus lateralis muscle is attached. And medial to the medial intermuscular septum, we are having vastus medialis muscle is attached. Both are anterior compartment muscles. So this is vastus medialis and here is vastus lateralis. And now we will see the muscles of medial compartment, means the gap between the medial intermuscular septum and the posterior intermuscular septum. This area is the medial compartment. Medial compartment contains adductor muscles. So medially adductor brevis in the upper part, adductor longus in the lower part, and adductor magnus all through its length. So the 3 muscles, adductor brevis, adductor longus, and the long muscle is the adductor magnus. So these 3 adductor muscles are attached between the posterior intermuscular septum and medial intermuscular septum. So what is remaining now? The gap between the lateral intermuscular septum and posterior intermuscular septum. So this part belongs to hamstring part. Already posterior compartment muscles mainly get origin from ischial tuberosity of hip bone. So the only muscle which gains its origin from here is the short head of biceps. So this is short head of biceps femoris. Short head of biceps femoris. So these are the attachments to linea aspera. So now we finished about the shaft of the femur, the anterior attachments and posterior attachments. Now let us understand the lower end of the femur. Anteriorly the medial condyle and lateral condyle, they are continuous with the saddle like continuation which articulates with the patella to form a saddle joint. So that is the anterior smooth side. Posteriorly there is a deep notch which is called as intercondylar notch, and here is the medial supracondylar line, lateral supracondylar line. Medial supracondylar line gives origin to medial head of gastrocnemius. Lateral supracondylar line gives origin to lateral head of gastrocnemius and also plantaris. So these are the muscles attached to the supracondylar line. Here is the medial projection of the femur near the medial epicondyle. This is called as adductor tubercle. So adductor tubercle is it is important because it gives attachment to adductor magnus, ischial part of adductor magnus. it has got a medico-legal importance which I will explain in clinical correlations. So, this is about the adductor tubercle which is present on posterior-medial aspect, and medial epicondyle of the femur also gives attachment to medial collateral ligament. Morphologically it is the continuation of adductor magnus muscle. Next about this lateral epicondyle, this lateral projection is the lateral epicondyle. Lateral epicondyle provides attachment to lateral collateral ligament which is also called as fibular collateral ligament of knee joint. We can appreciate the groove in the lateral condyle. This groove is for the tendon of popliteus muscle. The tendon of popliteus muscle passes through this groove and also it attaches into this groove. So, that is about popliteus muscle. Popliteus muscle is very important. It is an unlocking muscle of knee joint and it protects the lateral side of the knee because it is present between the lateral meniscus and the lateral collateral ligament of knee joint. It is an intracapsular muscle. The tendon of it is present in this groove. This is the popliteal groove. Next about the intercondylar area. This is the intercondylar notch. So, here is the medial, this large one is the medial condyle, the smaller one is the lateral condyle. So, the medial wall of the fossa, if you see this fossa, this is the medial wall and this is the lateral wall. The medial wall of the fossa provides attachment to upper end of posterior cruciate ligament. So, posterior cruciate ligament attaches to the medial side of the fossa. Lateral side of the fossa provides attachment to anterior cruciate ligament. The upper end of anterior cruciate ligament attaches to the lateral side of the fossa. Now, let us understand the clinical aspects associated with the femur. First foremost thing, fracture neck of the femur. So, here in this image we can appreciate 6 varieties of fracture. The first one, this one is the subcapital fracture where the head is separated from the rest of the upper end of the femur. And the second type is the transcervical neck fracture, the fracture in the neck of the femur. And the third is the intertrochanteric fracture, the fracture between the greater and the lesser trochanter. This is called intertrochanteric fracture which is along the intertrochanteric line anteriorly. And the next is the subtrochanteric fracture which separates the complete upper end of the femur from the shaft. So, the upper end includes the head, neck, greater, lesser trochanters. So, this fracture is called as subtrochanteric fracture. The fifth type is the fracture at the greater trochanter. You can see the fracture of the greater trochanter. Next one is the fracture of lesser trochanter. So, these fractures they are more common when the bone tissue is weak, and here in these areas especially the bone tissue is weak in advanced age due to osteoporosis or maybe due to bony malignancy, and this they are repaired either with the screws or by doing a procedure called hip replacement surgery. And in hip replacement surgery, the head of the femur and or the entire hip joint is removed and replaced with the synthetic versions. So, that is about the fractures. The next is the importance, medico-legal significance of ossification center of the lower end of the femur. So, here is an X-ray showing this one is the ossification center on the medial side near the medial condyle of the femur which appears just before birth. The secondary center for the lower end of the femur is unique as the sense it appears during birth or just before birth, that is the 9th month of intrauterine life, and it is of medico-legal importance because it appears in the radiograph indicating the maturity of fetus. So, this indicates the maturity of fetus. So, this ossification center, secondary center what we see here on the medial side, that is for the adductor tubercle. So, the secondary center at the lower end of the femur is unique because it appears just before birth or during birth, and it is of medico-legal importance because it appears its appearance indicates the maturity of fetus, and this center later forms the adductor tubercle of femur. Next is the angle of inclination. It is an angle between the long axis of the neck and the shaft of the femur. So here we can see the long axis of the shaft and the long axis of the neck. This angle is called as angle of inclination. Normally it is around 125 degrees in adults, and in children it is around 160 degrees. And in females it may be little lesser because of wider pelvis. So this is a normal angle of inclination, and second image what we see here, the angle of inclination is increased to 140 degrees. In adults, if it is more than 140 or 140 degrees, the condition is called as coxa valga. And here we can see the angle of inclination is reduced, and it is reduced much lesser to 105 degrees, and this condition is called as coxa vara. So we can see the angle of inclination, the two dots in the same line, and this is getting deviated above, and here it is in the below. So this is all about the angle of inclination. So this completes the osteology of femur. Thank you.